Okay, good evening, everybody. Welcome to this another session of 51st Comprehensive Course in Echocardiography. As usual, we'll be speaking a little bit about Giraffe Institute. We are located in Delhi. Now, all of us understand this is what we have is our auditorium. Many legends, including Dr. Prash and Dr. Nanda, are the part of this particular organization. Along with the newer one, Dr. Hansa Gupta, she belongs to Gurgaon and she's the one who has been the Vice President of Indian Academy of Echocardiography now. Two people who you have been talking a lot about them, and again is one Mrs. Reena Dua, and second is Dr. Narayan. And we have many accreditations from Indian Academy of Echo, International Society of Cardiovascular Ultrasound, Alabama, Delhi Medical Council. Then whenever we do a hands-on training programs, they are always get a permission from a Chief District Medical Officer in Northwest Delhi. We do run a one-year fellowship program in advanced echocardiography under the banner of Parur University. And we did conduct a BAPIO training academy program last year. We can say that we are the institute which started almost 25 years down the line in April 2000, and we are celebrating our 25th anniversary or silver jubilee on 17 August 2025. And now we are into this 51st course, which started on 9th April 2025 and likely to have a hands-on session in the month of October. Today is a 10th session consisting of 11 June 2025. We would be talking of TR and PR in the valvular lesions. And I'm Dr. Rakesh Gupta, again from Giraffe Institute of Echo and from Delhi. With this few words, let me switch over my presentations. I'll be talking about right tricuspid regurgitations. And before I talk about tricuspid regurgitations, certain things I would like to tell you. Look, whenever we talk about tricuspid regurgitations, it's a part of right heart hemodynamics. What does it mean by? Look, whenever we look for a mitral regurgitation, we look at what is the vena contracta is. Same thing we do in tricuspid regurgitation to assess its severity as mild, moderate, or severe. We have two more varieties in tricuspid regurgitations. But the important aspect in tricuspid regurgitation is not only the severity of TR, but how much is the gradient which is being generated in this tricuspid regurgitation is. And that's what is the most important part for any tricuspid regurgitation. Look, this is apical four-chamber view. This is also an apical four-chamber view. If you look carefully, LV and LA, they are smaller than RVRA. Right? On the other hand, if you switch on the colors, you find a severe tricuspid regurgitations. And if you look at the vena contracta of the TRS, we call them as mild, moderate, or severe tricuspid regurgitation. Similarly, if you go to short axis view over here, this is aorta, this is pulmonic artery, this is RA, and this RA goes by through tricuspid valve is connected to RV. And look at the proximal RVOT, is huge dilated proximal RVOT. Four different views talking of four different things. Similarly, if you look at this particular subject, with every systolic contraction, this is becoming more flattened as compared to diastole. Again suggesting that RV pressure is more than LV pressure during systole. I'm sorry to say that. It becomes more flattened in systole as compared to diastole, suggesting that RV pressure is more than LV pressure in systole. Four different pictures, in turns, they're trying to tell you or say you all the same thing. Normal intraatrial septal bulges towards the right hand side because LA pressures are 10 and RA pressures are only 5. And here the intraatrial septum is bulging towards the left hand side, suggesting that RA pressure is more than LA pressure. And that is what is important. If RA pressure is more than LA pressure is, means RA pressure is more than 10 millimeters of mercury. And this is what the basis of these hemodynamics. Well, till 2 years down the line, we used to say mean pulmonary artery pressure more than 25 millimeters of mercury at rest and more than 30 millimeters of mercury at stress is considered to be a definition of pulmonary artery hypertension. Correct. But this definition has changed recently in the sense that if you have a pressure more than 20 millimeters of mercury, is considered as pulmonary artery hypertension. This is 2018, which one was proposed. In 2022, it was adopted. So we have to look at the TR-jet gradients to assess pulmonary artery pressures. Let's look at them. How do we do it? This is the most common thing when we look at a TR-jet gradients. What do? We go to four-chamber view, as I showed in my last slide. Put a continuous wave Doppler across it, and then get the gradients. What is my peak gradient is? And here in this slide, the peak gradient is 4.4 meters per second, generating a gradient of 79 millimeters of mercury into the LA from RV to RA, not LA, RA. And this what gradient is, if you add RA pressure to it, it is known as peak pulmonary artery pressures. Now the question is, when we utilize pulmonary artery pressure, we utilize mean pulmonary artery pressures. So suppose this is 80, RA pressure is 10, it becomes 90. 90 into 0.6 plus 2.1 will give you mean pulmonary artery pressure. Remember, very simple thing, TR-jet gradient, peak velocity, peak gradient, add RA pressure to it, it will give you peak pulmonary artery pressure. And how do you develop mean is, whatever the values is, suppose this is 90 into 0.6, that is 54. Add 2.1, that is a constant. This is 56 millimeters of mercury. 56.1 millimeter of mercury is my mean pulmonary artery pressures. And this is what is virtually present in day-to-day practice in our scenarios. The only problem is we have a TR-jet gradients from different windows. When we talked about all these things, what are the windows where we can have a TR-jet gradients? The windows are, first of all, we have a parasolic short axis view at aorta. Second window is apical four-chamber view. Third window is focused RVRA view. Fourth window is RVRA inflow view, and fifth window is subcostal window. So wherever you get the maximum gradient, that's gradient we take them as a peak pulmonary artery pressures. So this is what is the importance of peak and mean pulmonary artery pressures in tricuspid regurgitations. Now the question comes, how do we assess tricuspid regurgitation? That is one hemodynamics. Now second thing is, how do we look at these pressures gradients? Sorry, the TRZ gradients. How do we really look at these TRZ gradients? So give me a second. I'll take out that file from my presentation. I hope you can see my slides. We look at a vena contracta width. If the width is less than 3 millimeter in size, it is mild. If it's more than 7 millimeter in size, this is severe. I'll try to hold this picture for you. Correct. So whatever the width is, we go to 4-chamber view. This is focused RVRA view. And we measure the width from this point to this point of a TRZ gradient. And this is what is known as vena contracta. In 2018 or 17, this was little modified. It was modified as less than 3, more than 7, more than 14 to 21 as massive, and more than 21 is considered as torrential. But at your level, even if you remember mild, moderate, severe, less than 3, more than 7 is considered as mild, moderate, and severe. But the important thing is this severity does not reflect to the gradients. Gradients which we have to calculate by ourselves to talk about severity of the tricuspid regurgitations. It's a little confusing thing. And I would like to confuse you more saying these words. If you go to MR, we used to look at mild, moderate severity of MR. But in tricuspid regurgitation, despite looking at mild, moderate, severe tricuspid regurgitation, the important thing is the gradients which are generated from it. Now, any one of you can ask me, what is the utility of looking at this tricuspid regurgitations? Well, we have to look at this tricuspid regurgitation severity by mild, moderate, severe in the sense we want to understand what is the cause of this TR is. Because TR is not an innocuous phenomenon. TR has got its own issues. What we are talking to you the TR is when we have a TR which is just based on a primary illness of the secondary illness of the primary lesion on left hand sides. So what we are looking forward, here is a patient who got his mitral valve replaced about 10 years down the line, came back with right-sided heart failure with severe tricuspid regurgitation. Look, this is a vena contracta from this point to this point, and this is definitely more than 7 millimeters of mercury. And if you look at the annulus of this tricuspid valve, this is about 42 millimeters of mercury. You cannot calculate it, but it is about 42 millimeters of mercury. So what is exactly the problem of this patient is his mitral valve is working okay, but the problem is now live with the tricuspid regurgitations. And today, in circumstances, if you look at this tricuspid regurgitation, which is more than severe, and annulus diameter is more than 42 millimeters absolute value, then we always tackle this TR jet gradient, TR, without or with any significant gradients. So TR has got gradients as well as TR per se by vena contracta. And that is what the difference between MR and TR is. This is another example of a tricuspid regurgitation. Look very carefully, very rare case which is seen over here is, this is a double chamber right ventricle. Look at the severe TR of this patient. Correct? Now this annulus is obviously dilated and gradient is very high. And here is a muscular band which divides from proximal RVOT to distal RVOT. This is a muscular band over here. Correct? So this is a turbulence across this muscular band. So what do we have? We have this patient who has got a double chambered right ventricle. He has got severe massive tricuspid regurgitations. Now issue is, we'll take care of this muscular band by doing a resection. What do we do with this TR? Obviously, we have to fix up this TR by doing an angioplasty ring to reduce the severity of this particular TR, which is developed secondary to double chambered right ventricle. Now, another example. This is a patient who has got a dilated cardiomyopathies. Look, I can understand this vena contracta is more than 7 millimeters of mercury. This annular size is dilated. And if it is a normal coronaries, what would be my choice of doing in treatment of this patient? I would like to fix up my LV first so that either I do by medical therapy or I do by my combo device therapy of CRT-D device to take care of this tricuspid regurgitations. Because I cannot fix this tricuspid regurgitation in this patient because this is secondary to the dilated cardiomyopathy. If this would have been because of mitral valve, I would have replaced the mitral valve and fixed up this by tricuspid annuloplasties. So it's a variation of the images which makes a difference. Here is another example of a patient of arrhythmogenic right ventricular dysplasias. They present with severe tricuspid regurgitation, but the gradient are less than 25 millimeters of mercury. And these, despite being severe TR, we do not do anything with them, just put a pacemaker device, AICD, to prevent them from a sudden cardiac death. And these patients, they reasonably behave well over a period of time. So quest of saying all these things together is, we have to look at the kind of a TR which we are getting. Either this is a primary TR or secondary TR. And based on that, we look at the vena contracta and the gradients. I'll stop at this point and take your questions one by one, because this is very important when we talk of a tricuspid regurgitation, when we talk of this particular modality, and when we say that tricuspid regurgitation is mild, and we get a gradient of 35 millimeters of mercury or 40 millimeters of mercury. To address this issue, now this is what I have taught you, absolutely a different work from what we have been doing in day-to-day practice. Kindly raise your hand. I'll call you one by one for your questions. Dr. Sharmeen Sultana from our online courses.
Assalamu alaikum, sir.
Wa alaikum salam.
Sir, we are found post-op repair patient with pulmonary regurgitation.
Correct.
In that case, how can we quantify?
Give me some time. Let me come back to post-op PRs. If you really look at a post-op PR, what exactly happened is we don't do anything with this post-op PR till the RVR they become dilated or they become hypokinetic.
Okay, sir.
And when they become dilated and hypokinetic, then the question is replacing the pulmonic valve. And I have not seen many people doing it. I could find a literature where only 2 people have done in India, that through percutaneous pulmonic valve replacements.
Okay, sir.
In fact, I'm following 2 of these patients of post-TOF PR, severe PR. And that's amazing PR. If you allow me a time, let me just try to see where I can look at this. I'll show you a slide where everybody will say, look, this is what the PR is. I have a presentation of the same thing, I believe. Give me a second. Yeah, I've got a presentation. You can see my slides. This is a classical patient of post-TOF. Now, look, there are 2 valves are present over here. One, this is left hand side. This is anterior, and this is left. So there's no anterior leaflet in this. Look carefully. You can see only 1 leaflet out here. There's no second leaflet out here. And when we have this, the patient will present with severe pulmonic regurgitation. And in this pulmonic, this is forward flow, and this is severe PR jet. And when we look at these kind of a thing, we look at the various functions of the RV. And if the RV start deteriorating, the only thing is either we replace this particular valve, and people have tried to replace by percutaneous valvular implantations. All right?
Yes, sir.
Dr. Muzaffar Ahmed Naik.
Good evening, sir.
Good evening.
Thank you for a good talk. I just want to know the vena contracta measurements. What is the relation of the cardiac cycle? At what point they are to be
Perfect.
taken?
Vena
And
contracta would be always in when? Systole.
mid-systole or?
Mid-systole.
Okay, sir. What is the relation of with the respiration, expiration and inspiration? Any?
Good question. Very good questions. Dr. Naik, what exactly happens is whenever we inspire, whenever we expire is, during inspiration, the RVRA pressure will, what will happen? They'll go up.
Up, increase.
Correct. And whenever we do expiration, the RVRA pressure will fall down.
Definitely, sir.
So we have seen that during inspiration, when we do a TR jet gradients, we always overestimate our TR jet gradients.
Okay.
And whenever we overestimate, obviously we are doing the same thing for a tricuspid vena contracta. So that during inspiration, we find more of a regurgitations, more of a gradient. And that's why we always say all velocity during end expirations.
Okay, sir.
This is a very, very important thing, because what exactly happens is sometimes these people, they have a very poor windows. For making a good window, what we do is we ask them to take a deep breath and hold their breath.
Okay.
And whenever they take a deep breath and hold their breath, what exactly happens? We start looking at a very good TR jet gradients. And that's what we are overestimating, the TR jet gradients.
Thank you, sir.
All right. Anybody else? Dr. Ramavtar Sharma.
Sir, good evening, sir. Sir, how to calculate mean pulmonary artery pressure in resting stage? How? Okay.
Dr.
Yes.
Sharma, how to calculate mean pulmonary artery pressure is, I said, look at a TR jet gradient.
Yes, sir.
And TR jet gradient, suppose my gradient is 50 millimeters of mercury. So the blood is pushing from RV to RA. Correct. And the
Yes,
blood
sir.
is pushing from RV to RA, then you add RA pressure to it.
Yes, sir.
So that what you will get is a peak pulmonary artery pressures. Suppose my TRZ gradient is 50. I have looked at a IVC that give me RA pressure of 10 millimeters of mercury. That becomes 60. 60 into 0.6 plus 2.1 will be a mean pulmonary
Mean
artery.
PH. Yes, sir.
And that should be always, believe my word, people do many things. But whatever the correct way is, always look for a TRZ in this particular way. Whenever you have a patient of real high pulmonary artery pressures, always look at the TRZ gradient in 5 different windows. To start with plaques, you go to parasmenic short axis view at aorta.
Yes, sir. Apical
Then
portion.
come back to plaques, go to RVRA inflow view. Come to 4-chamber view, look at the 4-chamber, then focused RVRA view in 4-chamber view, and then subcostal window. Wherever the gradient is maximum, that's what we take in practice. And you have to mention in your reports, look, this gradient was found in this particular window.
Yes, sir. Thank you, sir.
Dr. Shahbaz Kareem.
Yes, sir. Good evening, sir.
Good evening, Shahbaz.
Sir, basically, especially in patient of ASD, sir, atrial septal defect, we are getting bilateral flow, sir. In such cases, RA and RV both are dilated, so we are not able to especially measure the vena contracta. In some cases, I get difficulty, sir. Is there any way to combat this very problem, sir? The TRZ which is coming and the ASD left to right flow is also coming. So there is some difficulty in
Shahbaz,
calculating exactly the
I'm
vena
sorry,
contracta.
I don't agree with you. When the ASD flow will happen?
In systole, sir? ASD flow. Diastole, sir. Sorry, in diastole, sir.
And when the TRZ flow happens?
Systole.
Systole, sir.
So?
But the jet which is going towards the RA, sir, that is sometimes making difficult to.
I don't think so, man.
Okay, sir.
I don't agree. I'm sorry.
Okay,
There
sir.
are 2 different phases of a cycle, man. When the atrias are working, the ventricle has to be silent. When the ventriculars are working, the atria has to be silent. And if the PA pressures will go up, what will happen? The blood will not come from LA to LV. LA to RA. No, LA to LA. LA to RA. So there is no way that they are going to mix with each other. Do it next time.
Okay, sir.
We are there for another 6 months. Don't worry about it.
Okay, sir. Okay, sir.
All right. So let's move on to Dr. Priya Singh.
Good evening, sir.
Good evening, Priya.
Sir, can you please explain about the TR in prolapse tricuspid valve?
Priya, in case of prolapsed tricuspid valve, what exactly you want to understand?
Sir, the regurgitation we said if anterior is prolapse, so how the regurgitation is coming? The flow means.
Priya, you're asking me level 2 echoes, level 3 echoes. Let me just try to answer your level 3 echoes. You're lucky. I just got it for you. So let me share slide 126. What you are asking me, Priya, you are asking me level 3 of echocardiography. And I'm going to show you that level 3 echoes. All right, Priya, you have to be interactive now with me. So
Yes,
what
sir.
is this leaflet? This one.
This is a septum, sir.
What is this leaflet?
Anterior, sir.
It could be anterior, it could be posterior. It depends on the cut which we cut. Correct?
Okay, sir. Yes,
So
sir.
when we have this kind of a problem, we go to 3 dimensions echocardiography. In 3 dimensions echocardiography, what we look at is, we look at all 3 leaflets. Septal is over here, anterior is over here, the posterior leaflet is over here.
Okay, sir.
Correct? And then we look at this 3-dimension vena contracta, which is taken at, this is septal leaflet, this is anterior leaflet, this is posterior leaflet. So
Okay, sir.
whenever we see this anterior septum, anterior and posterior leaflet is, we calculate the vena contracta. Correct? Now, if my jet is originating between septal and posterior leaflet, or if my jet is originating septal and anterior leaflet, I'll be able to demonstrate that with a cardiac cycle. And this is same thing I'm trying to demonstrate you over here. Look, it is a mobile film, little bit still is a cumbersome, but because you have to identify this jet, in which cycle this jet is originating from where. And this is what we utilize in day-to-day practice in, like when we have to address this issue of a tricuspid vena contracta, this is what we do in day-to-day practice. It's a time-consuming job, but we have to answer whether this leaflet, posterior leaflet is prolapse, or anterior leaflet is prolapse, or a septal leaflet is prolapse.
Okay, sir.
And this gives you excellent idea about our TR jet and the gradients. And not only that, we look at the TR jet vena contracta area. We are not talking of vena contracta diameter now. We are focusing on this area of the vena contracta. Look, this is vena contracta where is single slice.
Yes.
So what we are taking a width as well as a depth to drive the area of this vena contracta. And that's what is being labeled now when we look at this vena contracta, their size of a vena contracta based on their severity. And this is good for when we are doing a tricuspid valve repair in cardiothoracic surgery. All right, I hope you are able to get some answers from this.
Yes, yes.
This is a
Thank you,
chapter by itself, to tell you very honestly. And what we all do is 3 dimensions echo when we talk in advanced skill training programs coming up in August now. When we talk of all these things during this 3 dimensions echo. All right.
Thank you, sir.
Thank you. Yeah, Tajinder Kaur, go ahead, Tajinder. Dr. Tajinder,
बड़ा
go ahead.
कंफ्यूजिंग लगा यस सर गुड इवनिंग सर
Good evening.
सर आज का लेक्चर बड़ा कंफ्यूजिंग और बड़ा फास्ट निकल रहा है सर कुछ भी पता नहीं पता चल रहा
इसमें क्या प्रॉब्लम क्या है? देखो हमें
सर एक तो फर्स्ट आपकी सर पिच वॉइस बहुत स्लो मुझे इतनी कंसंट्रेशन के साथ सुनना पड़ रहा है बाकी पार्टिसिपेंट की बिल्कुल ठीक है
मेरी वॉइस बहुत स्लो है.
हाँ जी सर स्लो मतलब पिच बहुत स्लो है लास्ट टाइम भी सेम ही था अब भी सेम ही है
Okay.
पता ही
Anybody
नहीं चल रहा
else?
कि
Is somebody are able to listen to my voice, which is slow?
Yes, sir. Today's your voice is little bit slow, sir. Mic, I think mic is far from you, I think, sir.
Mic is just
Even
close
in
by to me, man.
लास्ट
even in the
No,
last
sir.
lecture, sir, like I had to put my headphones on. Yeah, even the last it was low, and even now today it's been low. I thought it
Wait a
was in
minute.
only my system, but I think
My
it's
system is on a maximum right now.
Sir, I am listening your voice quite clear. I
सर
don't.
इसलिए समझ ही नहीं आ रहा कि वॉइस से सुने के क्या समझे, इसलिए मतलब इतना कंफ्यूजिंग लग रहा है आजकल।
I'm
like
sorry,
even in
Tajinder, because
last, so even in last lecture, in today's lecture, I had to
अच्छा सर
use my
लास्ट
headphones.
लेक्चर भी
Use
सेम
my
ही था,
headphones.
लास्ट
Otherwise,
लेक्चर
it
भी
was
आपके
fine. Yeah. Without headphones, it's not very audible, sir. This is last two lectures only. Prior to that, it was pretty fine.
so
प्लस स्लाइड सर अभी इतनी फास्ट फास्ट जा रहा है।
I'm sorry, Tajinder, because I didn't want to do that faster slide. I was trying to be as slow as possible. And okay, fine. Are you able to listen to my voice? I've got my this headphone as close as possible right now. And next time I'll make sure that I'll get in a headphone to speak into the voice mic so that you're able to hear clearly. Okay.
ओके सर, थैंक
So
यू।
let me continue with this topic and I'll be very slow. And in case we have still have a problems, we'll talk of this topic again. That's not an issue. So let me move on to my pulmonic regurgitations. So when we were talking of pulmonic regurgitation, the only place where we look for PR is parasternal short axis view at aorta. In this parasternal short axis view at aorta, we look at this anterior leaflet and we look at this left leaflet, which is commonly seen in 2 dimensions echo. Next is when we assess PR, we look at 3 different things: color flow mapping, pulse Doppler, and continuous wave Dopplers. Color flow mapping helps in detection of PR by color flow imaging. And how does the PR looks like? PR looks like as the blood is flowing from pulmonic artery to RVOT. Correct? Next important thing is PR is diagnosed by documenting a diastolic jet in the right ventricular outflow tract directed towards RV. Next is pathological PR is diagnosed or distinguished from physiological PR by a longer duration of flow, that is the whole of a diastole. And it's a wider jet as the regurgitation jet crosses the pulmonic valve. Means wider means what? Bigger vena contract. Whereas the functional jets, they are usually very small, central, and they are spindle shaped. So now we have 2 kinds of PR jets. One is very physiological, which are virtually seen in every subject. They are very small, tiny jets seen from pulmonic valve to RVOT. Pathological jets, they are wider, they are bigger in their vena contracta and they occupy almost whole of the diastole. In severe PR, as somebody was asking, what do? We look at the equalization of a diastolic pulmonary artery and RV pressure occurs early in diastole. So the color jet can be brief and inaccurate depending on the driving pressures, suggesting that if you have a severe PR, you may not see a very good recurrence or very good pulmonic regurgitation jet. The assessment of PR severity is usually estimated by diameter of the jet at its origin. The maximum colored jet diameter, that is the width or a vena contracta, is measured in diastole immediately below the pulmonic valve at the junction of RV outflow tract and pulmonic annulus. And that's all we do in parasonic short axis view at aorta. If the jet occupies more than 65% of the outflow tract width, in the same frame, it suggests possibly presence of a severe PR. If I had to say all these things in single words or a single sentence, the answer is the functional and pathological PR, they are two important things. Functional PR is very small vena contracta and tiny jets behind the leaflets of the pulmonic valve. Pathological jets, they are wider, large vena contracta, and they occupy almost the percentage of the diastolic time as well as the area of the pulmonic artery. Let's go and show a few features. Normal pulmonic artery is how much? The normal pulmonic artery is almost 27 millimeter in size, 26 millimeter in size. Here's a vena contracta which is almost 5 millimeter in size. Here is a vena contracta which is almost 8 millimeter in size. So it all depends on the severity. Now, what are the features of a continuous wave Doppler is? The density of CW signals provides a qualitative measure of regurgitations. Let me show you gradually some slides. Now look at this vena contracta. I hope you understand this is parasonic short axis view at aorta over here. Aorta is seen over here, and this is pulmonic artery which is zoomed up. Dr. Shamina Sultana was asking severity of a PR jet. Look, here is only one leaflet which is seen. This is what left leaflet of the pulmonic valve. Anterior is over here. There is no anterior leaflet seen over here. So what will happen? During diastole, the blood will flow back from pulmonic artery back into the RVOT. And whenever it flows back from pulmonic artery to RVOT, it will produce a turbulent jet going from pulmonic artery to RVOT. And this is what is known as vena contracta of that jet. Clear or not clear? Now let's look a few examples. A normal subject, look, very tiny PR jet, small, tiny. If I try to measure this PR jet, this is less than 1 centimeter, 1 millimeter. And just seen behind the leaflets during diastole. So it's about 2 millimeters maximum. Width is 24 millimeters. So this is pulmonic artery diameter, which is hinge point to hinge point. Then consequences of PR, that's what Dr. Sharmina Sultana was asking. If you
Yes,
have
sir.
a severe PR, what will happen? You look at a dilatation of LV and the RV functions. And
Okay, sir.
whenever the RV dilates and the RV function reduces, and that is where in tetralogy of Fallot, we try to replace the pulmonic valves. As far as I remember, I know like two patients have been done with percutaneous valve replacements. Now, how much? So what we do, we always measure the pulmonic artery width, which is 24 to 26, 27 millimeter in size. Then we measure the vena contracta from point to point. But important issue is, if you remember my past presentations, when would be the pulmonic artery maximum size? It's during systole. When we measure the PR, that will be during diastole. So the two measurements will happen in two different times. And when you measure these two dimensions, which is vena contracta. Here was RVOT diameter was 2.44. PR jet vena contracta is 0.57, which comes out to be 0.23% of the PR jet of a vena RVOT. Mild PR, 1/3 of RVOT diameter. Moderate is to 1/3 to 2/3 of RVOT diameter. Severe PR is more than 2/3 of RVOT diameter. That is a single dictum which we apply everywhere when we do a look at the severity of PR jet. So if you have a vena contracta, roughly less than 8 to 16 or more than 16, that is what is mild, moderate, and severe. Now, what is the importance of this PR jet? Look, importance of this PR jet is we follow up these people over a period of time, whether they are becoming progressive from mild to severe. And on top of that, another important thing is we follow the secondary consequences of this PR jet. What are these consequences is, as I said, evaluation of size and function of RV in the absence of any pulmonic hypertension provides indirect clue to severity of PR jet. We have taught about this, how to look for RVRS size. And how do we look for RV systolic functions? We are yet to teach about it. But basically, we have taught in TAPSE and RV free wall TDIs. So here is a patient. Any abnormality do you find in this subject? Anybody can raise his hand. If you look at this plaques view, any abnormality which you see in this place. If you look carefully, this proximal RV
is dilated.
become bigger in size. So as it is, we are looking at that RV, normal RVOT, proximal RVOT is how much? 27 millimeters again. Up to 34, max to max. So this size has become bigger in proximal RV. Now the same patients. Now we see there's one leaflet which is seen over here. This leaflet is completely gone. But pulmonic artery has not dilated. The proximal RVOT is dilated in this patient who has got a severe pulmonic regurgitation. And if somebody can really pin it out very carefully, look, there's something like patch over here. And this patch is much clearly seen in this particular window.
VSD patch repair
Of tetralogy of fellows. So this patient has got a severe pulmonic regurgitations. And when we have a severe pulmonic regurgitation, what will happen to flow between RV and pulmonic artery? The flow would be almost equalizations. So regurgitant flow will get equalized, will have a rapid deceleration time, which is seen over here. This is pulmonic forward flow. This is systolic wave. This is diastolic wave, which is regurgitant flow. Now, apart from that, where we utilize this pulmonic regurgitation jet flow in clinical practice. This is what early diastolic flow, if you take it as a gradient, suppose this velocity is 2 meters per second, the gradient would be what? 16 millimeters of mercury. Add RA pressure to it, it will give you indirect measurement of mean pulmonary artery pressures. I will repeat it again. Peak early diastolic velocity, gradients, add RA pressure to it, will give you mean pulmonary artery pressures. Late gradients, add RA pressure to it, it will give you mean LA pressures in the absence of any lung conditions. Okay. So that's what the importance of this PR jet hemodynamic. Same thing he has mentioned over here is PR jet velocity is 2.16 meters per second. So maximum PR jet gradient is 19 millimeters of mercury. Add RA pressure to it, it becomes equal to mean pulmonary artery pressures. End-diastolic gradient, which is seen over here, is 1.08 meter per second. Gradient is 4.68. Add RA pressure to it, it becomes to left atrial mean pulmonary artery pressures. Left atrial mean pressure in the absence of any lung disease. I hope this presentation was not confusing. This presentation was, I hope you are able to understand. If so, first of all, I'll request Dr. Tajinder Kaur. Yeah, good. She raised the hand by herself.
Sir, kindly explain again importance of PR jets.
Importance of PR jet in hemodynamics, right?
Yes. Yes.
Okay. So whenever we see a PR jet, this is forward flow velocity, this is reverse PR jet velocity.
Yes,
It
sir.
has got two components. One is the early, second is the late component. Early component is, when we look at this early component, we take a peak velocity, convert to gradients by utilizing 4v square as a phenomena of Bernoulli's equation. Then add RA pressure. How do we add RA pressure? By looking at IVC. So here the patient has got 2.16 meters per second. Peak gradient is 19 plus RA pressure. Suppose this is 5. So mean pulmonary artery pressure would be 24 millimeters of mercury. Similarly, if you look at this late gradient, that's just before the end of our diastole, the peak velocity is 1.08 meter per second. The gradient is 4.68 millimeters of mercury. Add RA pressure to it, it becomes LA mean pressures. And that's true in the absence of any lung disease. What is mean LA pressure, Tajinder? This is diastolic function evaluations. We look at EA ratio, we look at E2 prime septal, E2 prime lateral, take an average, and then we look at LA volumes index, and then we look at TRZ gradients. We'll be teaching about those things in a time to come. Okay? Is that clear, Tajinder?
Yeah.
Okay. Any other questions? Anything you want to ask again in tricuspid regurg? If not so, and just put your views back into the WhatsApp group. I'll be happy to take the next subject at your consensus. Somebody has written something in chat box also. Let me see. Volume is low. Yes, sir. Same thing I faced. Audible with headphone. Veena Pang says this. Next time I'll take in headphones so that you are able to hear it clearly. Attendance issue. Dr. Rakesh Singh want to enter now. And this is what exactly happens. People enter at the last minute for their attendance. Tajinder Kaur, go ahead and ask your clinical questions. Then I'll stop this recording and start recording for attendance.
Question, sir, but कि सैटरडे को रिकॉर्डिंग होती है, नेक्स्ट डे तो फ्रेश होते हैं, जल्दी सुन सकते हैं, पर इसकी रिकॉर्डिंग 2-3 दिन बाद आती है सर.
Okay. Tomorrow you'll get the recordings.
Thank you, sir.
Sir, I have a question, sir.
Go ahead.
Sir, not through the clinical, but for the attending, sir. Last time also I was
Just give me
present.
some 1 minute. Let me close this recording. I'll start the new one and then I'll take this questions. So I'll stop
Okay, sir.
over here